Welcome to another edition of Cracking the IR Code. I am Stacie Buck, President and Senior Consultant of RadRx. So this week's case, I have chosen a report that contains a lower extremity angiogram, thrombolysis, thrombectomy, and an angioplasty. So what I always like to do before I jump into the case details is I'm always going to start reviewing the clinical indication to make sure that I am selecting the correct codes based on the clinical indication. And I also want to look at the procedural steps to get a feel for all the procedures that the physician has performed, and then get an idea for the type of documentation that I want to look for each of the different procedures. So we see that the indication here is for a 72-year-old male with known severe peripheral arterial disease. So we see our occlusive disease clinical indication. Then also the indication mentions a CT angiogram performed at XYZ hospital that identified a thrombosed right popliteal artery with aneurysm. So we have a mention of occlusive disease, and then we also have a mention of non-occlusive disease. So in order to determine which codes we're going to assign, we need to determine what is the immediate clinical indication being treated for this patient. So now let's take a look at the procedural steps. So we start out with our ultrasound guided vascular access. Then from there, the catheter is placed for right leg imaging. Then in step number 3, the catheter is placed over the bifurcation with the tip in the right common femoral artery, placement of catheter in the distalmost popliteal artery, followed by additional angiogram for step number 4. So we had our initial imaging that occurred with the catheter in the right common femoral artery. Then the catheter was moved further down into the popliteal artery, and then additional imaging of the lower extremity was performed. Remember, we want to make sure that we have all of our required documentation in the report to support diagnostic angiography. We see in step 5 that there is TPA being administered. In step 6, we see a thrombectomy is being performed in the right popliteal. In step 7, we have an angioplasty of the popliteal. Step 8, we have an angioplasty of the right anterior tibial, and then we have a completion angiogram. So what we want to look for in our report, a thrombectomy was performed, followed by angioplasty. So in order to code an angioplasty for the same vessel where thrombectomy is performed, we have to see that a stenosis or an underlying stricture was actually treated. If the angioplasty balloon is utilized only for removing the thrombus, if it's to facilitate thrombus removal, then we're not going to code for an additional angioplasty. So that's one of the reasons why I always want to look at that procedure section first before I jump into the details. I want to get an idea of what I'm keeping my eyes open for in the report. Okay, so now let's look at the procedure details themselves. So we come down here where it says ultrasound guided access was performed. Ultrasound demonstrated a patent left common femoral artery with mild calcified plaque. And then it mentions the under ultrasound guidance, the common femoral artery was accessed. So the only thing we have missing here for the 76937 is a comment that permanent images were stored. The American College of Radiology has said that the report does not have to explicitly state that permanent images were stored, but they have to be able to be produced in the event of an audit. So personally, I feel best practices put that language in the report. If you are doing it 100% of the time, it's very easy to drop it into your template and have that as part of your documentation. If it's not documented, but you know for a fact that you are storing that permanent image 100% of the time, then you can still code 76937 if you know that you have that permanent image stored. So the access was at the left common femoral artery. When we start with that initial access, that is code 36140. However, that code is going to end up being bundled with the other work that we're going to do. After the common femoral artery was accessed, the catheter went to the right common femoral artery, which is a second order vessel, 36246. At that point, imaging was performed of the right leg, the 75710 with the RT. And when we get to the end of the case, I have a comment about the imaging codes that we'll take a look at. In our next paragraph, we see that the glide cap and glide wire were then passed through the sheath, past the area of thrombosis. Notice that I underlined thrombosis in the distal popliteal artery because that is the clinical indication that we're focused on. And then from there, the catheter tip was placed at the trifurcation. So now the catheter has moved from the common femoral artery down to that popliteal artery right before the level of the TP trunk. Physician injects contrast and then performs additional imaging, which will be coded with 75774. Again, we'll come back to the imaging codes when we get into the findings section of the report. Next paragraph, we see that TPA was administered for that thrombus, and then after that, a thrombectomy was performed. So as I already mentioned, I believe I mentioned it, the TPA is going to be bundled. If I didn't, I'm mentioning it now. The TPA is going to be bundled with the thrombectomy, with performance of the thrombectomy. Actually, when we're talking about administering TPA during any interventional procedure, there isn't anything separate to code for that. Code 37211 for the arterial thrombolysis, that actually is going to be for a prolonged infusion. That is not going to be when TPA is administered during an intervention. So for here, we're only going to assign a 37184. Then from there, a follow-up angiogram was performed after the thrombectomy. An angioplasty is then performed in the anterior tibial artery. You'll see that I've noted code 37228 with an RT. And then following that, a stenosis was treated in the popliteal, and that's noted with 37224 RT. So we clearly see that a stenosis was being treated in the popliteal artery in addition to that thrombectomy being performed. So we are going to pick up 37224. What you don't see right now here in this paragraph is a statement about stenosis being treated in the anterior tibial artery for 37228, but you are going to see it on the next page. So after the thrombectomy was performed, after the both angioplasties are performed, the procedure was terminated. So let's look at our findings paragraph. So the first thing that we want to look at in determining whether or not we're going to consider adding our diagnostic imaging codes, the 75710, the 75774, is do we have findings for these arteriograms that were performed? So when we look at the actual findings section of the report, we do see that that initial angiogram is showing the findings from that angiogram that occurred. Okay, so we see that we have that there. Then the catheter went down to the trifurcation, and then additional contrast was injected to then look at additional vessels. So we have the ability to assign the 75774 for that runoff to the foot. So we have the findings that support that. Now, one thing we don't know for sure about the imaging is whether or not the angiography was diagnostic, meaning was the decision to intervene based on these angiograms that were performed. We saw in the history that there had already been a prior diagnosis of a thrombus from a prior CTA, but the question is here, were these diagnostic or were they not? So this is an area where you may have to go back and query the physician and ask whether or not the imaging was truly diagnostic in nature to determine whether or not you're going to assign the 75710 and the 75774. So again, the findings are clearly documented. The question is, does it meet all of the CPT criteria for reporting because there was a prior study? So there would need to be ideally some type of indication in the documentation about it being diagnostic and about it resulting in the decision to intervene. So that's what we want to look for there. And so then just to review, or I'm sorry, let me go back for like a moment here. So we saw in the first page, I mentioned that popliteal stenosis was documented clearly for 37224, but we didn't see stenosis clearly documented for the anterior tibial artery. But we do see it here in the second paragraph of findings. We see anterior tibial artery demonstrated multifocal stenoses. So we know that we can assign that 37228 because that is documented there. And then again, we also saw the stenosis mentioned for the popliteal in the paragraph just above. And then when we come to the conclusion, we see where it says mid and distal right popliteal artery thrombosis with the known right popliteal artery aneurysm. So again, we're seeing this indication of occlusive disease. The physician treated thrombosis, the physician treated stenosis. So we used our codes for occlusive disease. The fact that the patient had an aneurysm and non-occlusive disease, which and it's non-occlusive disease, is not a factor. If occlusive disease had not been treated, then you're going to code this differently because an aneurysm would be considered non-occlusive disease. So that's why it's so important to look at your clinical indication, because it is going to change the coding. But in this case, with the stenosis, we know that we've treated occlusive disease, so we can ignore the fact that the patient had the underlying popliteal aneurysm. So again, in review, we have code 37184 for the popliteal artery thrombectomy. We have 37224 for the popliteal angioplasty, 37228 for the anterior tibial artery angioplasty, and then 76937 for our ultrasound guided vascular access. And then, as mentioned, there's a question as to whether or not the angiography was truly diagnostic, meaning the decision to intervene was based on the imaging. So if upon further research, it was determined to be diagnostic, then the following codes could be assigned, the 75710 and then the 75774. And then just some comments, some reminders on the coding rules. That 37184, that's assigned for the thrombectomy of the popliteal artery. Even though administration of TPA was performed, that is not going to be reported with code 37211. Codes 37211 through 37214 are reported for prolonged infusions when the catheter is left in place. The reason why we didn't assign any catheterization codes to this case is because our catheterizations are bundled with 37224 and 37228. So although catheterization codes are allowed with 37184, because they're bundled with the angioplasties that we performed, we're not going to report them separately. As a general rule, when you have two procedures that are being performed in this same vessel and one bundles your catheter work and one does not, it becomes bundled for both. You do not unbundle them. And then we saw the mention of stenosis for both the popliteal artery and then also for the anterior tibial. So that allowed us to code 37224 and 37228 for those angioplasties that were performed. If that had not been performed to treat the stenosis, and if the angioplasty balloon had been used to facilitate removal of the thrombus, then we would not have coded for the angioplasty separately. And then back to the 76937 for ultrasound guided vascular access. I've given to you here the comment from the ACR, where they said, while many radiologists may choose to dictate that permanent images were obtained, it is not required by CPT guidelines. However, it is strongly recommended that the procedure report note that permanent images have been achieved to protect the practice in event of an audit. So there's the best practice is to document it in the report. And then again, wrapping up, just another comment, reiterating the imaging for the 75710 and 75774. We had the initial angiogram that was performed via the catheter placement in the common femoral artery. Then the catheter went all the way down to the popliteal artery, and then additional contrast was injected, and then findings were given all the way down to the level of the foot. So hopefully you learned a few tips from this week's case, and I'll be back in 2 weeks with another one. Thank you.